Welcome to Top Med Talk. The Society of Cardiovascular Anesthesiologists annual general meeting is coming soon. Check out scahq.org now. More details at the end of the podcast.
Top Med Talk.
I'm very happy to be able to provide y'all with this information this morning in hopes to help you out building your own nutrition optimization programs. No disclosures for me to report today. And what I'd really like to go over today are just very briefly comparing an ERAS and an optimization program, really spending most of the time describing this new role for dietitians in the surgical space, and then a summary of how we implemented our program and also some of the barriers that we ran into to try to minimize you guys having those same barriers. So very briefly, some of you might be thinking, well, we already have an ERAS program, and so why do we need an optimization program? And I found this image that I thought really highlighted well the phases of an ERAS program and highlighted a lot of the areas where nutrition is important. And you can see in that pre-hospital phase, there's an entire optimization section. And so that's why, while the ERAS is very crucial, an optimization program is just as important so that we can get these individuals as prepared as possible before getting to the hospital. And that's all I'm going to mention about ERAS and a perioperative program, an optimization program. Really, now I'm just going to dig into how we built the program. One of the first great articles I would like to show is this perioperative quality initiative looking at nutrition screening. And so this article does have a great screening tool called the Perioperative Nutrition Screen. Very quick, just 3 steps and 1 lab that you're going to look for using an albumin, unplanned weight loss, if the individual has been eating less than 50% of their usual, and then if you have an albumin, looking for a low albumin under 3.0. Now, this was the first step in our build, was identifying how are we going to look for these individuals. So you do need a screening tool initially. And with that screening tool, we developed this survey to hand out in our pre-anesthesia clinic to have patients fill out the top half. Providers, I'll show you on the next screen, did fill out the bottom half. And this survey is going to have 2 purposes. The purpose number 1 is to identify our individuals in our area at risk of malnutrition. We know from the literature that many individuals are at risk of malnutrition prior to surgery. But hey, maybe our area is a little unique and people are generally more healthy. So we do need to survey our patients in our area to see if this is a risk, a concern for us. You can see highlighted in the red and green boxes, these are the questions pulled from that nutrition screen, the perioperative nutrition screen with weight loss and their eating. We did also ask on this survey if patients were interested in meeting with a dietitian, just starting to plant that seed that there may be some additional providers that they are meeting with prior to surgery. Now, we used this survey just for 1 week in our pre-anesthesia clinic, and you can see our results were consistent with the literature that roughly 30% of our patients headed to the operating room did screen positive or at risk of malnutrition. This is probably not unique. I just want to point out that it's 80% of the patients coming through PASS going to the operating room. Not everyone that comes through our pre-anesthesia clinic is going to the surgery. Some are just having endoscopy or colonoscopy, but everybody received the survey because we weren't sure which they were going to have. But again, just under 30% did screen positive for having one of those risk factors. So yes, our patient population, not unique. There is that need for a nutrition intervention. The second part of using this survey was also trying to identify, well, are there enough individuals that need to be seen that we need to hire a full-time dietitian? And so running through the numbers, that 28.6% of individuals, this ran out to be 12.6 patients per day that are screening with at least one of those PONS criteria, the perioperative nutrition screen. Even if we take into account the 57% of individuals who did say yes, they would like to meet with the dietitian, came down to 7 patients per day who were screening at risk of malnutrition and interested in meeting with the dietitian. And this did meet our needs at our institution for hiring a new RD. I'll point out, all of this stuff happened actually prior to me being hired. This was a lot of behind the scenes, just trying to figure out, do we need the nutrition optimization? Do we have enough patients? And the answer was overwhelmingly yes. Now, you may be in area and thinking to yourself, well, gosh, my hospital system, we're just a small community hospital and we really don't have that many surgeries per year, that you may not have these numbers for patients at risk of malnutrition. So I would like to point out a couple different areas where you may be able to find additional individuals who are in need. One of those areas is diabetes. And in the 2021 standards of care from the American Diabetes Association, you can see that it is highlighted target range for glucose in the perioperative phase should be 80 to 180. This roughly translates to an A1C between a 7.5 and an 8.0%. So using this information, I went back to our patient schedule and just did a rough count of how many individuals might also need nutrition evaluation based on their A1C. I just counted up A1Cs that were available, and for the month, there was over 100 using that 80% and figuring out business days. It did come down to about 4 individuals a day who have an A1C over 7.5. Add that to the 12.6 who had a positive PONS screen, and now we're up to 16.6 patients a day who are in need of a nutrition intervention prior to surgery. In addition to the diabetes, there are some surgeries specifically who are using a BMI to get some further optimization prior to surgery. Now, this I had pulled from the orthopedic surgeons, the American Academy of Orthopedic Surgeons. And so this one is highlighting total knee replacements with a high BMI as a risk factor. At our institution, there are surgeons who want a BMI under 40 prior to a revision of a knee surgery. Other surgeries that I've worked with to lose weight prior to surgery do include things such as spine surgeries, pressure ulcers, ventral hernia repairs. We also have some insurance companies here in the US that do require a BMI under 35 for a breast reduction. So there are a lot of opportunities for overweight, obesity, and some weight loss prior to surgery with the same goal of enhancing outcomes and making surgery safer for the individual. The next step in building your perioperative nutrition clinic is to figure out, well, gosh, these patients are already seeing so many people. When is the patient going to meet with nutrition? And we had decided that, well, we'll get an office in the pre-anesthesia clinic, put the dietitian in that office. So when they are there for the pre-anesthesia testing, And if they meet criteria, if they screen positive for a PONS, they can go ahead and just walk down to the dietitian's office same day. Let's make this as easy as possible for patients. Let's just add on same day. They're already there. No need to go park and drive someplace else. And that was our next phase. We just add a dietitian into that perioperative space, into the pre-anesthesia clinic specifically. So now that we know that the dietitian is in the perioperative clinic, we do need to decide on a screening tool and who will be using that screening tool. Now, I know I had mentioned this perioperative nutrition screen, the PONS, previously, and this is what we had used while we were screening our patient population to determine if we had enough malnutrition patients or patients at risk of malnutrition to necessitate hiring that dietitian. I would like to point out, for a screening tool, using a percentage could be found to be too cumbersome. Unless your medical records are doing some percentage calculations for you, which I think would be great, you're going to have an extra step or two to calculate out a percentage. And so we did decide in our implementation that we actually converted that percent into pounds. So we were now looking and asking the question, if an individual had lost more than 10 pounds in the last 6 months, and we did away with that percentage for the screening process. I do want to show you some other screening tools, specifically for malnutrition screening tools that have been validated. You can see 4 different tools listed here. They are validated in different populations, so you do need to be mindful of your patient population. And you can also see here that some of them do continue to use a weight loss percent as a screening criteria. One last tool that I will show you is the Strong for Surgery program, which is now part of the American College of Surgeons. They've got a real nice website, and they've got some pre-made handouts, one included being this nutrition screening checklist. And this is one of those screening tools, the malnutrition screening tool. It's called MST. Just using a BMI, which is automatically calculated for us, asking about that unintentional weight loss. This one uses 8 pounds over 3 months. I really do like the way they asked about poor appetite, getting a little bit more specific with eating less than half of their meals or fewer than 2 meals per day. It's noteworthy that some individuals naturally eat 1 meal per day, and 1 meal per day, even if that's their usual, simply is not going to be enough nutrition to prepare for surgery. So I do really like how this one separated out that question. And lastly, this screening tool does also use that albumin to check to see for a low albumin prior to surgery. So second step in your build, figuring out what screening tool is going to work for your clinic. Is there one already in place? Great. Does it work well? Do we need to revamp something geared more towards surgery? Or are you guys good to go because you've already got one in place there? The last component with this build prior to starting to see patients, it is figuring out the logistics of how is this patient going to get to the dietitian and all that behind the scenes stuff that needs to happen. For us, we needed to include during this step individuals from our billing team. We had to make sure our IT support was included because we do bill for nutrition services. So we had to make sure for insurance requirements that we were dotting all the I's and crossing all the T's. So we did have to pull in a lot of team members for this final piece. We also were blessed to have a poet nurse navigator who in our clinic is kind of like the air traffic controller. This individual does a fabulous job with the provider, letting the nurse navigator know there's a patient to be added on that day. Nurse navigator assisting with the scheduling, assisting with the front desk, assisting with our lab's going to be first, our lab's going to be second. And so our nurse navigator, if you don't have this as a role, I would highly suggest looking into it to have this kind of go-to point person to really help with the facilitation. This is a big last step for us. Hopefully, with some of your clinics, it may not be as involved, this final piece, getting the patient to the dietitian with all of the criteria being met that needs to be. But this was our final step in our build. So just as a quick recap from the build, we did a survey that was twofold. One, to assess our patient population. Are they in need? Are they at risk of nutrition? Part two of that survey also helped us build our case for hiring a new dietitian. We then figured out our patient flow. We were going to add dietitian, nutrition optimization into our pre-anesthesia clinic. Figured out the best screening tool for our clinic, and then ironed out that referral process that we needed to do here. Now, briefly, some of you might be thinking, well, I'm already doing the nutrition. It's just part of my pre-anesthesia. And I'm going to go through just real quick what the dietitian is doing in that appointment and why I highly recommend that you do refer on to nutrition professionals in this space. So this is just a brief what we're going to go over in the appointment together, reviewing why are they seeing nutrition. They may be saying to me, gosh, this is my 5th surgery and I've never had to meet with nutrition before. This is something new. So we talk about why they're getting a nutrition referral. We briefly go over their medical history. We definitely go over their weight history, ups and downs, and what's happening with their weight, as well as how they're eating recently. Dietitians now do a physical exam. We are assessing fat and muscle. So that is very important component of our assessments with patients. And then we do, of course, go over items like our anthropometrics, labs, and medications, as well as supplements with the individual. Now, the bulk of the appointment is really educating. Our goal, again, is to improve outcomes. We want to reduce infection. We want to reduce their length of stay. We want to reduce their readmission. We want to do surgery, send them home, have them follow up in clinic, and be happy and healthy on their road to recovery. So with this education, it is a reinforcement of why are they getting this education, to improve their outcomes. How are we going to improve their outcomes? We're going to do our best to improve their intake with a focus on protein. You can probably imagine a lot of these patients, when they're being referred to nutrition, they just automatically think, well, gosh, I have to eat more fruits and vegetables now before surgery. So I'm usually very happy to tell them, no, we're actually not going to focus on your greens right now. It's protein. That's going to be the part that really helps with healing. So they are excited and it's something new for them. So with protein being the focus, a lot of these individuals have ended up in my office because they are not eating well. That means that the option of eating bigger portions to get in more protein isn't really an option. It means the option of adding more snacks per day might not be an option if they just don't have an appetite or if they're having some pain while they're eating. This leads us to most of the time recommending a supplement, some kind of a beverage to get in that extra protein. I try my best to not force patients to choose the supplements. I want to provide options for getting in more protein and let them choose what's going to be best for them. Most of them do choose the liquid protein because of the situation that they're in. Recommendations are going to vary. The screening tool is not a diagnostic tool of malnutrition. And so with the nutrition assessment, that is where we are going to decide, does this patient meet malnutrition criteria? Are they still in this at-risk phase of malnutrition? And that will depend, along with other things, how much protein we're going to recommend. Roughly, we're going to recommend about 1.5 grams per kilogram. And just to let you know how this could play out, for an individual who weighs 150 pounds, taking in 1.5 grams of protein is going to be up to 102 grams of protein per day. That can be difficult for a healthy individual eating their regular meals and snacks. So I just wanted to highlight that. That is why we tend to go down this road of the nutrition drinks and supplements. One other note with nutrition drinks and supplements is I put a lot of different images. There's lots of different brands these days out there. And I always want to remind patients, if you have tasted one of these brands 10 years ago and you didn't like the taste, they have changed their recipe and they have new formulas. So if it's been even 1 year, they've probably changed their recipe. Go ahead and you can try that same brand again, or there's lots of new brands coming on the market, so give a new brand a try. They do shockingly all taste different. So do encourage them to try different brands if they have had something in the past that they just weren't fond of. The key here is making sure or doing our best to get the patient this additional protein that they need. So it's working with that individual with what's going to work for them. One other supplement that we do discuss are the Immuno nutrition supplements. There are 2 on the market right now. You can see they're just different nutrition profiles. One, the Ensure version being an 8-ounce carton that's recommended 2 shakes per day for 5 to 7 days. And then the Impact Advanced Recovery. This is a smaller carton. It's a 6-ounce carton. And so that is why the recommendation there is the 3 cartons per day for 5 days prior to surgery. These are not uniformly recommended. The guidelines from ESPN actually state that there is no clear evidence for use of the immunonutrition versus the standard oral nutrition supplements in malnourished major cancer surgeries. Having said that, some specific ERAS guidelines do recommend the immunonutrition. The colorectal is the one that stands out in their ERAS guidelines, that they do recommend the immunonutrition prior to surgery. So the immunonutrition is not across the board something we recommend for everyone. I will note here in the US, they are much more expensive than our high protein or our standard oral nutrition supplements. And that is something else just to be mindful of who you're working with and taking that into account. Will this individual be able to afford them? Or do we need to do something to help assist them? Or are they going to be okay using a standard or a high protein oral nutrition supplement? So two different supplements. Protein is really what we are focusing on with the education. And then to complete the appointment, we do talk about specific goals for them. The main one being, what is their meal plan? Are they doing 3 meals, 3 snacks, 3 shakes? Are they doing 2 meals a day and 4 shakes? This really depends on what their intake has been. Most individuals are going to end up usually drinking 3 shakes a day. Again, it just depends on what is their starting point. That's the main thing we're focusing on. How much are they taking in? So it's that meal plan. Some individuals really like numbers, so I would give them a daily protein goal. Others, they're overwhelmed as is and they don't need an additional number to track. Along those lines, they also are very stressed getting ready for surgery, and I don't need them weighing themselves. We do want their weight to remain stable. We're happy if they're gaining weight prior to surgery. We really just don't want their weight loss to be trending down as they approach their surgery date. But there is no requirement for them to gain their weight back prior to surgery. There is also no requirement to get their albumin within normal levels prior to surgery. If albumin was the referral reason, that's great. We'll go over their nutrition, but we don't need that within normal limits prior to the actual operating date. And then for some individuals, we're going to discuss enteral nutrition or perhaps parenteral nutrition, as that's going to be the best way to meet their goals. And then the final component with nutrition is the follow-up. If we are meeting these individuals a month prior to their surgery, we're going to follow up weekly to see how they're doing with those goals we set. We had recommended 3 meals and 3 shakes. Were they able to get out to the store to get their shakes? Did they taste them and not like them? Do we need to alter the recipe, add it into the blender with a scoop of ice cream? Is that going to help them get these shakes in? We're going to follow up and see how they're doing. And we will do follow-up not just preoperatively, but also postoperatively until they are 1 month out from surgery. All right, so go team. We built this. We've got the dietitian seeing patients. They're doing great. They're drinking all the shakes with no issues. And you can see here what some of the outcomes can be if left untreated. With the preoperative malnutrition, there is that increase for infection and a slowed recovery, delayed recovery. We want patients eating quickly. If you keep them NPO, that is also going to increase in risk for infections, as well as the potential for a delayed recovery. Surgical stress from a nutrition standpoint, we can't do too much in the operating room, but we are going to try to minimize and really focusing on that early nutrition. After surgery, we want early nutrition if that is most typically going to be an oral supplement. So it was not smooth sailing for us. I told you that up front. We definitely ran into some barriers. And so I'm going to run through some of the barriers we had to hopefully help you guys navigate so you're not running into the same roadblocks we had. Minor roadblock here as I figure out my screen. Okay, so one of the first barriers that we ran into was providers, their buy-in. Why are we now all of a sudden referring to nutrition when we've been doing this ourselves in the anesthesia clinic and surgery clinics? So we've talked about nutrition. Why do we need to send out for the dietitian? So what we found was we really needed to have our pre-anesthesia providers part of the team early on while this was being developed. During the build, have them included in the why are we looking for a dietitian? How are they going to help? And it's that education. Patient success stories from your dietitian are also very powerful. And I also like to point out that pre-anesthesia providers, they are busy. So why don't we let them refer out? We don't need to be putting more on their plate. We want to encourage them to refer out. Let the nutrition professionals handle the nutrition component, and they can continue and really focus with their anesthesia exam, their pre-anesthesia exam. Another potential barrier that we had was, okay, great, we've got the providers on board, but now the patients are saying, well, my surgeon never told me anything about this. So making sure, again, that the whole surgical team is included in this build and getting to your surgeons and letting them know they may have to start talking about nutrition as well and letting their patients know at pre-anesthesia, you may be referred for a nutrition visit. We also had these great flyers that we were able to hang in some of our surgery clinics that really helped the patient become empowered and to let the patient have more control over their care. Having these flyers was a great way for the surgeon and the patient to start that conversation of how is their nutrition getting ready for surgery. So I think these flyers are a great thing to have, great reminder for everyone. All right, one of our biggest barriers was actually not having enough time for surgery. In our proposal, we had said, patient is at the surgeon's clinic, they will refer to pre-anesthesia, we'll have the dietitian in the pre-anesthesia clinic, same day appointment, they move on to surgery. What we found was that pre-anesthesia appointment was only 2 to 3 days prior to their surgery date. And so that was just simply not enough time. What we did here was actually multiple things. And while we still have nutrition referrals coming from the pre-anesthesia consult, we went backwards through the patient journey and added additional time points where a referral to the nutrition clinic can be made. So when the patient is being scheduled for their pre-anesthesia consult, those schedulers can also, using specified criteria, can also add a nutrition appointment. When the surgeon is placing the referral for pre-anesthesia, they can add a nutrition consult. And we also said, well, right from the surgeon can place the nutrition consult. They don't need to wait to come to pre-anesthesia for this. We used a lot of our IT services. We got some good IT support here. And this is what our Epic screen looks like for when the surgeon is placing the referral for pre-anesthesia. And I've just highlighted there how they can select this individual needs nutrition optimization. This is our screen from Epic of when the individual is being scheduled for their pre-anesthesia appointment. And these are the screening questions. So we've included that weight loss question with the scheduling that they can add nutrition appointment. We also wanted to make it easier for the providers in pre-anesthesia to be notified this patient is screening positive for one of these risk factors. And so using from our vitals, we were able to create this system where on the provider's schedule, these green and red dots will appear, and the red dot there, that is where an individual has screened positive. They've got one of those risk factors of malnutrition. And this is just, again, helping support our team and highlighting the provider even before they are in the clinic room with that patient, that this individual has screened positive for malnutrition, for risk of malnutrition, excuse me. All right, some other potential barriers with the patient. One had been distance. With everything going on, of course, the advent of telehealth really skyrocketed here. And so that has really been helpful. And then patient cost is another barrier. So using your sources, your hospital pharmacy, can we get some of these nutrition supplements at a better price point? If there are coupons available or even parking vouchers, any little bit can really help with that price point for some of these individuals. So as you can see, even if you have a fabulous ERAS program, the perioperative enhancement team, these optimization programs, they really do work together. Your ERAS, I don't believe, will work as good as it could without these optimization programs. Remember, it is that first line, that pre-hospital phase, building up these individuals before they get to the hospital. And ERAS and optimization are consistent. We are not going against each other. Our recommendations are in line to help support these individuals and improve outcomes. So final here, just to wrap up, this is really your to-do list of how you can build your steps to building your optimization clinic, getting your research organized, start talking, who is going to be a champion, who is going to be a positive vocal person for you, making sure that you've got a good positive core group, checking your numbers, getting the right location, educate all the time, lots of education, not with the patients at this point, educating staff and bringing your team together because that team is going to be really a big key for having a smooth build. All right. Well, thank you for your time this morning. I really enjoyed doing this talk for you guys.
Top Med Talk.
The Society of Cardiovascular Anesthesiologists' 44th annual meeting is coming soon, and Top Med Talk will be there. If you want to pop along and see us, it's on May the 14th to the 17th in Palm Springs, California. Check out scahq.org now for special offers and more details. Also, if you're not sure if you can make it in person, why not explore the virtual track? Innovation during COVID-19 now means more than 60% of this year's sessions will also be fully available for you online. Check out scahq.org. That's scahq.org